In this second educational module, I will discuss how some aspects of immature sucking, swallowing, and respiration can lead to oral feeding difficulties.
More specifically, I will address some of the problems arising from immature sucking, be it bottle or breastfeeding, prolonged swallowing and respiratory processes, as well as the immature coordination of these three activities. This slide, included in our first module on the fundamentals of oral feeding skills, is a reminder of the descriptive scale I developed, presenting the evolution of the 5 sucking stages that occurs as sucking matures. The important features I want to point out here is the gradual appearance of the expression and suction components along with that of their respective rhythmicity. Please note that the expression component matures before that of suction. The sucking recorded during bottle feeding here is from a 59-day-old preterm infant born at 27 weeks gestation. The top channel shows the suction component and the lower channel the expression component. During the 30 seconds identified by the red arrow, this baby took 3 ml of milk. As you see, during the first 20 seconds, she attempted some suction, but primarily used a rhythmic expression-only sucking pattern, about a stage 3A if you use the descriptive scale shown in the previous slide. After that time, she switched to an alternation of suction expression, approximately a stage 3B. There are 2 points I want to make here. 1. Infants can switch back and forth in their use of expression only and alternation of suction expression. At a later time, I will discuss why we think this happens. 2. This tracing illustrates that during bottle feeding, an infant can feed by mouth without using the mature sucking, i.e., the alternation of suction expression. The use of the expression component alone can be sufficient for a baby to complete a feeding. However, as we have shown in an earlier study, it is less efficient, namely, it will take more time to complete a feeding. So for now, we know that if a baby uses only the expression component due to immaturity, she may have difficulty completing a feeding within a given time period, for instance 20 minutes, as we know that expression alone is not as efficient as the alternation of suction and expression. Immature breastfeeding is a different story because a bottle nipple is not like a maternal tit. A bottle nipple has a certain rigidity, whereas the maternal nipple is soft and even retractable. The infant does not need suction to retain the bottle nipple, but very likely needs suction to retain the maternal nipple during breastfeeding. As such, it is likely that the suction component is necessary in order for the infant to latch onto the breast. This assumption is based on common sense more so than evidence-based data. Nevertheless, it is supported by the frequent anecdotal observations that preterm infants early on, when introduced to breastfeeding, cannot remain latched on to their mother's breast. However, latching on to the breast can be facilitated by the use of a nipple shield. It is likely that the rigidity of such shield, which is similar to the bottle nipple, allows infants with weak or no suction to remain on the breast. Therefore, an immature sucking with no suction may prevent infants from breastfeeding because without the suction component, they cannot retain the maternal tit in their mouth for the duration of a feeding. However, I would like to add something as food for thought and consideration. There may be an advantage in offering the use of a nipple shield early on because it would give time for the baby to develop the mature alternated suction expression sucking pattern while experiencing breastfeeding and being held by their mother. It is also encouraging mothers to maintain their lactation, to provide their own milk for their baby, be it given through a bottle or breastfeeding. I am reusing the non-nutritive sucking and nutritive sucking tracings of these two preterm infants that I presented in the previous module to emphasize that the early maturation of non-nutritive sucking can be used as a good marker of sucking skills, but not of nutritive sucking. As discussed earlier, nutritive sucking implicates not only sucking but also swallowing and respiration, and most importantly, the adequate or proper coordination of sucking, swallowing, and respiration. So if we take the baby on the left, we can conclude that he has good sucking skills, but his feeding problems indicated by his immature nutritive sucking stage are not due to sucking per se, but rather to swallowing, respiration, and or uncoordinated suck-swallow-respiration. However, we should not ignore the other benefits of non-nutritive sucking. Indeed, non-nutritive sucking has its benefits. For instance, it allows greater weight gain, promotes behavioral organization and nipple feeding. It decreases distress and may decrease energy expenditure as a result. It also increases gastrointestinal motility, non-nutritive sucking-induced analgesia. Non-nutritive sucking therapy has been demonstrated to accelerate non-nutritive sucking development as well as oral feeding success. However, it does not increase circulating levels of gastrointestinal hormones such as gastrin, mutilin, insulin, or IGF-1. Immaturity can lengthen the swallowing process, which in turn can disrupt the proper coordination of sucking, swallowing, and respiration. Let me give you some examples. Safety in oral feeding lies primarily in preventing aspiration into the lungs, and safety requires the proper timing of the epiglottis closure over the larynx in order to prevent such aspirations. So, with an immature swallowing process, aspirations can occur prior to swallowing due to poor bolus formation, during swallowing due to improper epiglottis closure over the larynx, or after swallowing due to residual liquid around the valleculi and piriform sinuses that will drain into the larynx when the epiglottis opens. Also, silent aspiration can occur. It has been reported that in neurologically based dysphagia in children, 94% of the aspirations are silent. Awareness of aspiration is primarily due to the cough reflex. As such, it is unclear whether silent aspirations are due to the absence or decreased cough reflex, resulting from immature neurological signaling or immature chemoreceptors in the larynx, as speculated in a recent study. In the previous module, when I discussed the maturation of respiration, I mentioned that the respiratory rate of infants at rest is around 40 to 60 breaths per minute, and that their swallowing can last between 0.35 to 0.7 seconds. Now I want to use some of these numbers to do a simple math problem. Presume that a baby breathes 60 times per minute, or once per second, and his swallowing lasts 0.7 seconds. He only has 0.3 seconds to take a breath. In addition, we know that during oral feeding, there is a decreased minute ventilation, or tidal volume times the respiratory rate, a prolongation of expiration, and a shortening of inspiration. Therefore, one would expect that over an oral feeding session of, say, 20 minutes under such conditions, an imbalanced O2-CO2 exchange will occur, understandably leading the infant to respiratory distress during his feeding. Let's talk now about the coordination of suck, swallow, and respiration. We may not know what the proper coordination of these three functions ought to be. However, we do know what would be best for our babies. Indeed, we want to minimize aspiration and optimize O2-CO2 exchange, basically sufficient breathing time for air in and out. Up until recently, such coordination was presumed attained with consistent ratios of suck-swallow-respiration, such as 1:1:1 or a 2:2:1 ratio. Simply put, it is believed that rhythmicity in the three functions is key. However, a few years ago, based on my work, in addition to rhythmicity, I have added another stipulation, namely the importance of a safe swallow-respiration interfacing. By interfacing, I mean that swallowing needs to occur at a phase of respiration that is the safest, i.e. the least likely to lead to aspiration as the bolus travels from the pharyngeal passage down to the esophagus. I will discuss this latter aspect in more details in the next few slides. Now let's look at the coordination of sucking, swallowing, and respiration as a chain reaction. In the diagrams on the slide, I have represented the individual functions in green when they are appropriate and red when they are inappropriate. What do we have? If sucking, swallowing, and respiration are coordinated, all I know is that my baby looks happy. He's green. If these three functions are uncoordinated, my baby looks unhappy. She's red. But I cannot determine whether her unhappiness is due to suck-swallow incoordination, which in the chain reaction would also lead to inappropriate respiration, or whether it is due to swallow respiration incoordination, because either way, my baby looks unhappy. Presume it is due to uncoordinated suck-swallow. One can ask the following questions. If sucking is adequate, the green light, are the oropharyngeal swallowing skills up to par? 1. To rapidly form the bolus. 2. To transfer the bolus to the posterior pharyngeal wall to initiate the swallowing reflex. Remember that the intrabolus pressure needs to be sufficiently strong to propel the bolus before it breaks up. By the way, this is the reason why certain practices use thickeners, because they maintain the liquid bolus as a whole for a longer period of time. With solids, there is no such issue, as the bolus remains well formed. 3. To clear the pharyngeal area rapidly, so liquids do not linger in the valleculi and piriform sinuses, increasing the risk of aspiration when the epiglottis reopen. The table on this slide shows the maturation of the suck-swallow coordination. Remember how I mentioned earlier the importance of rhythmicity for the coordination of suck-swallow respiration. The data presented in this table are from a study we conducted a while back. We compared the estimated average bolus size and the rates of sucking and swallowing between preterm and term infants. The preterm infants were very low birth weight infants born less than 30 weeks gestation. These infants were monitored between 34 and 37 weeks postmenstrual age at 2 time points. At the introduction of oral feeding, when they were taking 1 to 2 oral feedings per day, and at the time when they reached independent oral feeding, i.e. no tube feeding, when they were taking 6 to 8 oral feedings per day. The full-term infants were monitored during their first week of life and between 2 and 6 weeks. They were all fed ad lib. The value presented are the average monitored at those 2 time points and presented as means plus and minus standard deviation. The bolus size of our preterm infants averaged 0.14 ml or 3/100th of an ounce and was significantly smaller than that of their term counterparts who averaged about 0.22 ml or 6/100th of an ounce. For comparison's sake, as adults, our average bolus sizes vary between 10 to 25 ml, if not more. 10 ml is approximately 1/3 of an ounce. The sucking and swallowing rates were similar within each group of babies. However, both sucking and swallowing rates were significantly slower in the preterm than term infants. Term babies showed an average sucking rate of 1 cycle per second, as we expect for nutritive sucking. As I said before, regardless of where the incoordination occurs in the suck-swallow-respiration chain reaction, my baby will look unhappy. But it would be important and informative to identify at which level the incoordination is occurring. So let's presume now that sucking and swallowing work well together, the green boxes, but not between swallow and respiration. What could be some reasons why swallow and respiration are uncoordinated? Let's backtrack a little bit now. We know that in term infants and adults, swallow occurs at any phase of respiration, but primarily during expiration, start of inspiration, end of inspiration, and during respiratory pauses. On the other hand, we showed that preterm infants primarily swallow at sucking pauses, during inspiration, and during deglutition apnea. By the latter, I mean that these infants are sucking and swallowing without breathing. In this slide, I want to define swallow-respiration interfacing, a term I referred to earlier. This is a measure of when swallowing takes place in relation to the various respiratory phases. This diagram shows the respiratory cycle, white line, with inspiration upward and expiration downwards. Theoretically, swallow can take place at any time during the respiratory cycle, i.e., at start of inspiration, during inspiration, end of inspiration, during expiration, end of expiration. It is also conceivable that swallowing during inhalation may shorten the duration of inspiration, as I label this 5I. In a similar manner, swallowing during exhalation may shorten the duration of expiration, shown as 5E. If inspiration or expiration were shortened, as shown in 5I and 5E, we could expect O2-CO2 exchanges to be jeopardized. Finally, swallowing may also occur during deglutition apnea when the baby stops breathing. Deglutition apnea is defined here by periods of no breathing equal or greater to 2 seconds. Before I go on further discussing swallow-respiration interfacing, I want to show you what deglutition apnea looks like. These recordings show from top to bottom the suction component, time in seconds, the expression components, the swallowing event, and respiration at the bottom with inspiration upward and expiration downward. This baby is sucking and swallowing nicely, but between the two dotted vertical red lines, he stopped breathing. This lasted for about 15 seconds, after which time breathing restarted. Note, however, that about 5 seconds before this happened, his nutritive sucking pattern began to deteriorate. The suction and expression amplitude decreased, and rhythmicity was not as regular. Although the respiratory alarm did not yet come on, we took the bottle out after 5 seconds after he started breathing again because he was turning blue. This is a good example showing how babies will stop breathing when sucking and swallowing. This likely occurred as coordination of suck-swallow respiration was falling apart. This table shows the frequency at which the different swallow respiration interfacings occurred in the infants we monitored from the study mentioned a bit earlier. Again, as a reminder, The preterm babies were monitored at 1 to 2 and 6 to 8 oral feedings per day. Their term counterparts were monitored during their first week of life and between their second and sixth week of life. In brief, what you can see is how, with maturation, infant swallowing will occur more frequently at different phases of respiration. Preterm infants first swallowed most frequently during deglutition apnea, as I showed you they can do in the previous slide. The second most frequent swallow-respiration interfacing is swallowing during inspiration, followed by the start and end of inspiration. It is conceivable that during inspiration, the pharyngeal transport of the bolus is facilitated by the influx of air into the lungs. Unfortunately, as the bolus follows the path of air intake, risk of aspiration would increase as the epiglottis is open to let air into the lungs. Term infants during their first week of life also swallow during deglutition apnea, followed by start of inspiration and end of expiration. However, after 2 weeks, they primarily swallow during start inspiration followed by end of inspiration. End and start of inspiration are the safest times to swallow, as no air goes in or out. So with maturity, as represented by the changes observed from the preterm to term infants, we see that swallow occurs at safer phases of respiration. In this module, I have presented some of the issues that may arise with immature sucking, swallowing, and respiration. With all this information in mind, how can we define readiness to oral feed? I believe that readiness to oral feed is difficult to define because the coordination of sucking, swallowing, and respiration is not a rigid event. With maturation, each of these functions can rapidly adapt to various situations, such as to maintain an adequate level of overall coordination. For instance, in regards to sucking, we now know that infants can switch readily between the use of expression alone to the alternation of suction expression. Insofar as the use of expression alone is not as efficient, this would indicate that infants can use this approach to decrease flow rate. Their ability to switch from a more immature to a more mature nutritive sucking pattern tells us that infants can regulate their own flow rate. In regards to swallowing, with maturation, we know that the swallowing event occurs faster and infants can handle or swallow varying bolus sizes. Maturing respiration, we know, leads to better oxygenation, and respiratory rate will eventually decrease as tidal volume increases. The plasticity of these three functions in turn implies plasticity of the Suck-Swallow-Respiration Coordination. This offers a broader latitude within which sucking, swallowing, and respiration can remain coordinated. Until we gain a better understanding of such latitude, the happy face of a baby during feeding may be our best indication of readiness to oral feed. In summary, I have presented to you some of the evidence-based causes, and by no means all of them, by which immature sucking, swallowing, and respiration, along with their uncoordinated activities, can lead to a number of different oral feeding difficulties.